Good afternoon. My name is Rob Morrison, and I serve as Executive Director of the National Association of State Alcohol and Drug Abuse Directors, or NASDAD. Thanks a lot for joining us for today's convening. It is the single state agency dialogue on drawdown of substance use prevention, treatment, recovery services, block grant supplemental funds. Before we begin, I'd like to review some housekeeping items. Today's meeting will include small group and large group discussions. So please make sure you're on mute unless you're sharing a comment or answering a question. Closed captioning is available. To turn on closed captioning, click the CC Live transcript icon located on the bottom of your Zoom screen. And if you experience any technical issues during the webinar, please message us using the chat feature, which is located at the bottom center of your screen, or you can also email samhsateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. And the recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Next slide, please. I'm going to read this disclaimer slide so that we're all on the same page. The views, opinions, and contact expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Substance Abuse Treatment or the Substance Abuse Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide, please. So we're here to review the agenda a bit before we have some opening remarks from leadership at SAMHSA. You can see here after remarks, we'll go ahead and talk a little bit about the day, but mostly this is about you and the discussions that are important to successfully share lessons learned and challenges regarding spend down. We hope to walk out of here with some practical advice and some learning as we navigate this important issue. So with that in mind, I'll ask for the next slide. And I think we're going to change the order unless...
I am here, Rob.
Excellent. Tom Coder serves as Principal Deputy Assistant Secretary at SAMHSA and is always adept with wonderful timing. Tom, the floor is yours to provide some opening remarks.
Thank you so much, Rob, and good afternoon, everyone. I think it's afternoon. Most places, it might be still morning in some places that folks are calling in from, but welcome. And first and foremost, happy Recovery Month, everybody. September is National Alcohol and Drug Recovery Month, and I got to spend some time with your executive director, Rob Morrison, on the National Mall last week at the SAMHSA's Walk for Recovery, and it was an amazing time to kind of get together and celebrate all the progress that we've made over the years together, states, local communities, community-based organizations in supporting people like me to find and sustain their recovery. So thank you for that. We're really excited about today's webinar, and we really appreciate folks from states for joining in. This is going to provide us an opportunity and a forum for all of you, whether it's SSAs or the block grant coordinators, to participate in a dialogue about what some of the barriers are and what some of the strategies are that you've been using to spend supplemental funds. And the reason as we've been talking about this, whether it's been at the NASDAD meeting or the NASHBID meeting or in other meetings like this, is that we got some resources, unprecedented resources, thanks to Congress and the Biden administration. And, as a result of the COVID pandemic, and we have an opportunity to not leave those on the table. And that's what we're trying to make sure that we do, that we share some of the strategies folks have had for using those resources in innovative ways in your states. This is important not only to SAMHSA, but we do hear from our friends in Congress who provided these funds on a regular basis, asking for updates. We know that you guys are hearing from your governors and your legislators. We know you hear from providers and the people who are service recipients. And so this is important pretty much to everybody. And that's why we're spending so much time on it. And we know that your time is valuable. So we're trying to make sure that we do this in a structured, coordinated way, and that we are meeting you where you are. So we know for some of you, this hasn't been a problem. Some of you have just been able to hit your stride and get these resources out. Others are somewhere in the middle where you're getting the funds out, but you might need another idea or two, or a push or two to continue to do that. And then there's another group that may need additional help. And so that's what we're here to provide, to really be able to work with you on any of the issues that you're having around spending of the ARP funds primarily, but COVID relief funds and other funds that you're receiving at the same time. And it's our goal just to be able to be as supportive as possible in this process. So on behalf of Dr. Delphin Rittman, who would have liked to be here today, but she is at the Secretary's Tribal Advisory Council out in Washington State today. She sends her regards, but on behalf of her, on behalf of SAMHSA leadership, and our friends in CSAT, who you'll hear from in a minute, it's really our distinct pleasure to be able to work with you on this, and to work closely with our friends at NASDAD to be able to get you the assistance that you need. We appreciate everything you do every day to serve people who are at risk or who are struggling with a substance use disorder. Help them, like I opened up with, be able to find what I found, recovery in the long term. So with that, I'll turn it back over to you, Rob.
Thanks for your comments, Tom, and happy Recovery Month. And while I was there, a large number of folks from our office, they were there as well, joining in the march and recognizing the importance of recovery and Recovery Month, alongside Eric Tadahara, the winner of the Ramsden Kennedy Award for 2024. So thanks for your leadership. Next up, we have another speaker from SAMHSA leadership, Dr. Ingvild Olsen. She serves as director of the Center for Substance Abuse Treatment to provide remarks as well. Dr. Olsen.
Great. Thank you so much, Rob. And just want to really quickly say hello, good afternoon, welcome, good morning if you're still on the West Coast. I think this is the kind of gathering that that I get really excited about, because it is an opportunity for us to hear from you all, for all of that, the peer-to-peer sharing and learning as well. I know that these are some of the challenges that you're all going to talk about today and you're going to raise today are challenges that that we really want to be able to help you all kind of work through, and some of the successes that you've had are also things that we really want to be able to highlight, because the dollars that, as Tom mentioned, the dollars that have come from Congress to help support just the continuum of prevention, harm reduction, treatment, and recovery support services for people who are at risk for or living with substance use disorders, they're so incredibly needed. Yesterday, I was actually in Tennessee with and was able to hear from Marie Williams and check in with her. I was meeting with a number of the opioid treatment programs across Tennessee and the State Opioid Treatment Authority. Today, I'm in Missouri. I'm going to be also touring an opioid treatment program on Thursday and giving a talk tomorrow at the Missouri Behavioral Health Council conference. I'm going to Nevada on Friday began to talk with some OTPs, and I think just going around and really hearing from all of the innovative work and all of the efforts that are being made across your states, across your communities, to really make sure that people are getting access to all the necessary services that you're helping to support with all these funds, whether it's COVID supplemental funds or the ARP funds, those are just, they're really life-saving and unbelievably important for people's recovery. So I just want to say thank you all for all the work that you're doing. I know, having been a little part of kind of the Maryland state system for a little bit, that sometimes it's really hard. And but we're here to support you. We're here to work with you, and really the team that is here to kind of help and the collaboration with NASDAD is just so wonderful. And so just really looking forward to today and to additional work together. So back to you, Rob.
Thanks, Dr. Olson, and thanks for your leadership at CSAT. And many of you may know Dr. Olson provided direct care and continues to do so in some form. But I got to visit her program, and that you didn't just provide a little help in Maryland, you provided a lot of help to a lot of people. So thanks for your work. So next up, I think we're gonna review a little bit of what we'll talk about, as we alluded to earlier, in the breakout rooms. So you can see here, we'll have 7 breakout groups, and each group will have in it a facilitator and a note taker. You can see here, while you'll get further instructions from the facilitators, you can see here basic core questions you'll consider, including challenges, ways you've used to solve those challenges, success, and things you found to be helpful, and innovations. I think now we know innovations are the rule, not the expectation. And you all have led the way in providing that leadership at the state level. And so continuing to share those innovations has been a priority. From there, you'll come back after about 35 minutes. We'll do a large debrief. I'll call out a representative of the group. You will determine who reports out. It'll be either the facilitator or a state. And then we'll walk away. We'll wrap up after the report outs, and you'll have somewhat of a timed report out, so that we make sure we get to every group and learn. So that's what we can expect from the breakout groups and the debrief. From there, I did want to introduce another member of the SAMHSA team, Spencer Clark. Spencer is going to provide some level setting, building off of Tom Coderre and Dr. Olson, regarding the work that we're doing here. He serves as chief of the State Systems Partnership Branch, including work on the block grant in particular within the Division of State and Community Assistance. Spencer has spent a number of years working on these issues, including his leadership in the great state of North Carolina. Spencer, the floor is yours.
Thank you so much, Rob. And it's a pleasure to be here. We're so happy to have all of you here with us today to share many of your successes and challenges. My role today is really to kind of just give a little bit of level setting of kind of how we got here. Many of you have, as Tom Coderre has already pointed out, have done an exceptional job of really using an unheralded amount of funding that we have been very fortunate to receive. And we just got a little ways yet to go to complete this particular part of the project. We are very pleased to have Rob, NASDAD, and JBS assisting us in this process today. In way of level setting, most of you are aware, but some of you may not be aware, this money came to us back in 21 we had actually 3 separate pots of money. The initial COVID-19 funding was 1.65 billion that came to us in March of 21 with a 24-month period of expenditure, which has been extended twice through no-cost extensions. The COVID funding, the ARP funding came to us in May, 1.5 billion with a 49-month period of expenditure through September of 25. And then later that year in August, we received another $50 million that was specifically oriented towards COVID testing and mitigation. And that also expires in September of 25. And for all 3 of these funding awards, Tom Kadir and then Dr. Delphin Ripman have provided rather extensive guidance letters, which are available to you from your project officer. I'm going to cover some of the points of those letters in terms of some of the original architecture that we envisioned for these fundings. The overall, in terms of the COVID supplemental funding, the purposes were to promote effective planning, monitoring, and oversight of all of your services, prevention, intervention, treatment, and recovery, particularly provide support for providers who, as you remember, were going through some pretty difficult times back in 21 with the restrictions and the pandemic itself. Also use these funds for maximizing efficiency by leveraging infrastructure and building capacity, and then also address a variety of SUD related needs in the COVID pandemic. In the treatment area, some of the areas that we would like for you all to address that we addressed back in March of 21 are integrated SUD treatment with particular focus on pregnant women and new mothers, which is a historic source of reference for the block grant. Medication-assisted treatment, which we now refer to MOUD, for FDA, with FDA-approved medications for both opioid use disorder and alcohol use disorder. Crisis services, as you know, has come a long way with the 988 system. So these dollars were also anticipated to help respond to the prevention of crises and responding to crises in particular for persons with SUD. Operation of access lines, crisis lines, and warm lines, purchase of technical assistance, and then, of course, COVID-19 specific related expenditures regarding testing, vaccines, transportation, et cetera. 2 other areas of support that we were looking for with these dollars were recovery support. We've really been on the move in terms of recovery the past several years, but we anticipated this with these dollars that you could be providing support for recovery community organizations, peer-run organizations, peer recovery specialists, again, operation of crisis lines and recovery-specific lines. Other areas are infrastructure, purchase of course, personal protective equipment for staff and persons receiving services, connectivity, Wi-Fi, technological things that were needed to have more telehealth and more services delivery in a pandemic era, hiring of outreach workers, and provision of workforce support, which again has been really challenging during the pandemic. One of the areas that I am going to differentiate the COVID-19 funding from the ARP today is the COVID-19 funding, as you all know, is on a no-cost extension, which means that we are not doing any brand new projects out of that funding. Everyone on the line here submitted plans to us back in March and May of 21. We approved those plans. So your COVID-19 funding, which expires in March of 2025, those dollars you are using to continue to complete your original plans that were approved. You're not allowed with the COVID particular funds to be doing brand new and different things that were not in your original plan. And of course, your original plans have been filed in WebBGAS and are available to both you and to your project officer to look at what those plans are. In the way of ARP, that funding came very shortly after the March funding. The areas that we were really interested in there were, again, making sure that we are really supporting FDA-approved medications and digital therapeutics, increasing the use of low-barrier approaches to treatment. We've been really looking at trying to do more things in the way of the drug overdose epidemic. As many of you are aware, we've been working with a variety of cohorts with naloxone saturation. That's an area that we are very interested in doing whatever we can to begin to make more progress in that area. Improving information technology and infrastructure and adoption of new health information technology. These are some of the areas that we are expecting that you can use these dollars for, as well as things like telehealth and unique activities that are reaching out to, particularly to rural populations that have traditionally been difficult to serve. In the way of, we actually sent out another letter in March of 2023 to just really emphasize some new areas. Again, the prevention of overdose and low barrier access to SUD is a critically important to us. We've been trying to do everything we can to make treatment more welcoming, more accessible, and so forth, particularly in areas where persons are needing medications, and we're trying to provide those services both in mobile services as well as telehealth. Crisis services, I've already mentioned, really looking at how do we move persons from crisis into care. That might be working with hospital emergency departments, making sure those individuals who are experiencing overdose or at risk for overdose are getting effectively engaged into treatment, and then as they move through the treatment pathways into recovery and on from there. Recovery support services, I'm going to talk about a little bit more. We've made some great strides with recovery in the past several years, including the standing up of a whole recovery office here at SAMHSA, and really a lot more robust activities in the area of recovery. Promoting resilience among children, youth, and families. We're very concerned about that area, and particularly as the isolation and some of the other issues related to the pandemic have affected young people and their families. And then last but not least, behavioral health workforce. We know that we've experienced some difficulties there with both recruitment and retention. We're wanting to work hard on things that we can both improve our access to professionals, support those professionals in care, and take care of our workforce. A couple of things that just want to remind you of, with both the COVID and the ARP funding, the set-asides for primary prevention are required, as well as set aside for HIV for those states that are designated states. The regular SUBG or SUPTRS block grant restrictions are in place. If you have a question mark about those, we can work with those. Those are outlined, as you know, in the statute and regulations. The one exception to that is that the ARP COVID testing and mitigation supplemental funding are not under the block grant regulations. So those dollars are really specifically oriented towards testing and mitigation. So the regular block grant funding regulations are not applicable for that particular pot of funding. I want to mention the Consolidated Appropriations Act in 2023, which is took place December 29th of 2022. They changed the name of our block grant from abuse. Now it's substance use, prevention, treatment, and recovery services, and expanding explicitly to more heartily embrace recovery support services. We followed that very year with adoption of a robust set of recovery support services. And we are now, as you are aware, requiring our grantees to tell us about what they are doing in recovery support services, both planning and reporting on a regular basis. Those recovery support services range from things like individual and group peer supports, educational and health and wellness activities, cultural and social support activities, recovery support organizations. Recovery housing is a big area that we've really used a lot of the COVID funding for targeted housing. High school and collegiate recovery programs, recovery-friendly workplace. And then we've also provided support for persons who are seeking to seek treatment or recovery through support of either childcare or transportation as necessary for persons to participate in these kinds of activities. And then, of course, the activities that you all are doing to train a peer workforce and peer certification, those are also activities that we support with these funds. In the way of harm reduction, that this has been an area that we've also emphasized a great deal more in the past several years. The most visible aspects of those are, of course, the naloxone and other opioid overdose reversal medications through the block grant, and the purchase and distribution of fentanyl and xylazine test strips. We also, as I mentioned, been working hard to support naloxone saturation activities, and these block grant funds and COVID and ARP funds can be used for that as well. Last but not least, I will want to mention that the block grant funds, including these funds, may be used with your support from your project officer for syringe services programs. So we have a variety of activities there, from provision of comprehensive HIV risk reduction activities, linkages regarding hepatitis, SUD treatment, supplies, testing kits, syringe disposal services, navigation, a whole host of things there that we would welcome you to look at that. We have a fairly simple process for you to receive approval to use block grant funds to support syringe services programs, with the exception, of course, of needles and syringes, which we cannot purchase, but everything else, there's a whole cadre of activities which we'd be very happy for you to be able to use these funds for, to support some of these more refined harm reduction activities, which we know are oftentimes precursors for persons being able to get into treatment when they are ready for that. You've all submitted plans which have been approved by us in CSAT for both the COVID and the ARP. We are eager to work with you when you need to make amendments to those plans. Your project officer is your go-to person for that. We do that through a simple process, through a revision request process through WebBGAS. But we like to follow a philosophy. I had a vision director in North Carolina that gave me the philosophy that Spencer tried to say yes, and that's a bit of our philosophy here. We're going to work with you as generously as we can within the boundaries of the block grant. But if you have innovative ideas regarding your COVID or the ARP funding to do things that are going to make a difference in your state, let us hear about it. We're going to work closely with you to accomplish those tasks. Thank you, Rob.
Well, thank you, Spencer. Thanks for those perspectives, the grounding, and that'll set us up very nicely as folks go into their each individual group. So you will be taken there automatically, the folks on this Zoom call, and then we will see you back after your discussions, where we will begin the report out process. But if you have any challenges, please use the chat function, and also reach out to JBS in case you are not automatically taken there, but we'll be close by. And just as a reminder, those are the questions we'll be considering, and your facilitator is going to walk through these as well. So have a great discussion, and we'll see you back here in about a half hour. Thank you and welcome back. I appreciate you taking the time to dialogue. Now's the time where we're going to report back out your findings, observations. We're going to do so with an eye on 3 minutes per group. I know it's tough, but we want to make sure we hear everyone and their observations. The one recommendation we have to make things efficient is to try to not duplicate responses that other groups have reported out, and that'll help refine, maybe save a couple of seconds. So, you know what? I heard group 7 first. So I'm going to go to ask group 7 to report out, and they will have identified someone to report out for them, either facilitator of the state, and group 1, be on the lookout. You're next. So group 7.
Okay, well, I should have kept my mouth shut. I didn't realize by saying we were back, that meant we would be first, but that's okay. Somebody had to be first. And Rob, I'm sorry, but you gave them a way to get out when you said it would be either the facilitator or one of them. So of course, my group had no problem with the facilitator doing this. So here we go. We had some great discussion, and I just want to point out that very often when I facilitate groups, it's the complaining and the challenges that seem to want to go on and on forever. And that was not the case with my group. They identified the challenges pretty quickly. They weren't unusual, and we moved right on into some of the great things that they've been doing. And I think they kind of fell into 3 kind of broad buckets. And so I will just mention that, and I'm sure other people may have the same buckets, but might have some other ideas. One strategy was to look at existing programs and see what kind of add-ons they could do, how they could expand, so they didn't have to start over from scratch, getting something up and going, but could add on to something. And in their Michigan's case, they were looking at new engagement centers where they had not been able to do it in the state. And that was a bucket. Another bucket was workforce development. They could offer more training. They could look at the pipeline, recruitment and retention bonuses, things they had never been able to do. And then finally, the third big bucket for us was looking at those one-time expenses. So they could add new technology, telehealth, modernize what they had, and also the idea of capital expenses, be able to set up mobile treatment units. They had the money for those initial capital expenses that they could then keep it going. So I will leave it at that. I thought those were 3 great areas that the fabulous great states in my group brought to light and shared in terms of what they had been doing.
Excellent. Thank you very much. Appreciate that modeling of staying at 3 or under. We're going to go to group 1. Group 1, you can report out, please.
And call on you, Sissy McKenzie of Kansas.
Our
Hopefully you can
group,
find-
I apologize, I wasn't sure I was in group 1. Okay, so as far as our largest challenges is spending down the supplemental funds, it seemed like our group, the majority of the states had a little more trouble with both the resources on the state side, as well as doing the contracting, doing the RFAs, that kind of thing. So we all kind of got a little slower start on getting the contracts out the door and then the services implemented, as well as maybe some of trying to be very targeted with the funding. None of us were Medicaid expansion states. So we were pretty much with pretty limited funding in our state. So how are we going to sustain those services and those funding beyond whenever the funding was finished? So we're still working through those challenges, but as far as successful initiatives, one of the things that we did, at least in my state and others, was we were able to implement some medications that we weren't able to do before, such as for our state, we were able to supplement opioid use disorder medications through SOAR, but we weren't able, because of diagnosis, able to do medications for alcohol use disorder, and also some of the tobacco use disorder medications that folks could use. So those were really wonderful ways that we were able to use the funding. Also, one of the states talked about doulas and being able to do those, incorporate those in the peers workforce and recovery coaches. And then another one was a lot of the new recovery housing services that we weren't able to do before. So if anyone else on our team has anything else that they would like to highlight, please feel free, but that was the majority.
Fantastic. Another model presentation at 2 minutes, 30 seconds. Well done. I'm going to ask group six to report out.
Hi, Rob. It's me from Rosie from Idaho representing Group 6. Do you want us to talk about all the challenges or just the successful initiatives?
We're hopeful for a mix of both if you could choose a few.
Okay. So people have already talked about, trying to avoid fiscal cliffs because anything you start, we didn't want to create a cliff when it ended. Reporting challenges because there were multiple funding sources coming in from all over the place. So the reporting and just our procurement processes can take, as every state knows, can take way too long to get done. And then one state was going through a big merger, and so there were changes in leadership, and that created some challenges for Utah. How did we resolve them? Some states attempted to streamline contracting processes. Again, that's easier said than done. And just close collaboration with partners and trying to figure out contingency planning so when the funds do run out. So the best part of the conversation for me anyway was what are some of the successful initiatives that we did. I'll start with one we did here in Idaho. We called it Third Space, and we put privacy pods in primarily libraries, but public places, so that particularly rural Idaho, so that folks that had challenges accessing telehealth can go into a library, and we put in these great, fantastic pods and we've trained the librarians, and then people can come in and use. It's not necessarily just all for behavioral health because we were worried about confidentiality. We didn't want it to be like, oh, everyone that goes uses the privacy booth is there for behavioral health situation. Those have been fantastic. We've got 22, I think Rachel said, up already with another 20 in progress. And we had Blue Cross of Idaho actually heard about this and funded a handful of them as well. Those have been really great. If anyone's interested in that, we did work with Northwest ATTC, and we have a guide to help anybody who's interested in setting up a model like that. But those are great because they're one-time expenses, and then it's up to the library or the location to keep doing that. I can't remember which state this was. It might have been Utah that funded Root recovery-based community organizations doing first touch, pre-treatment, and post-treatment connections. This was interesting to me. In fact, I'm going to look into this. They contracted with King's College out of the UK and have implemented this new substance use recovery evaluator, or the SURE, to identify if someone's in crisis. And now the recovery organizations in that state are using this tool. Funded some mobile MAT clinics. Another state funded treatment for PPW in residential centers, really focusing on family care plans. And that's been so successful, they're figuring out how they can continue that. I think that's probably enough unless somebody else from my group would like to. I want to just say one other thing we did with the flexibility of the funding. We also did some, we brought Oxford House finally into Idaho using these funds. But with the housing assistance program, because there was the leniency where we could use the funds to actually help people stay in their own homes and pay their rent and utilities. We did it for up to a certain dollar amount or up to 6 months, whichever came first. And it was for folks in treatment or who had recently completed. And that was especially during COVID when people did not have, a lot of folks weren't working. They didn't know how they were going to pay. So rather than losing their existing housing, we were able to let them stay where they were. Does anyone from the group have anything else?
Fantastic. Thanks a lot for that. And I think you're illustrating the different considerations about allowable uses that are important to walk through. So thank you very much. I'm going to ask group 2 to report out.
I'm gonna ask Quinetta Womack. The floor is yours.
Hey there, Quinetta Womack from Louisiana. I will avoid some of the duplicative reports and say ditto to a lot of the groups with the challenges. So I'll just focus on some of the other challenges we identified as a group. And one of the things is the timeline for expenditure in year one. Sometimes it takes around 6 months or so for the planning, negotiating, contracting before we can even start to expend any of the dollars. So when you look at the tracker, it may seem as though we're not really spending money because we've been in the negotiation and planning phase the first 6 to 8 months of the award. The other thing is sometimes some of our initiatives, we may spend those or draw down those funds on the back end versus the front end of the award. So it also may look as though we're not expending, but the intent is to spend it on the back end. We also have some delays in our revised proposals. Our recommendation is to try to get a quicker turnaround when we are submitting revisions to our proposal to expend those funds. And one of the last things we mentioned is that oftentimes providers may back out of the partnership, especially when it comes to a 2-year limit. And so we have to renegotiate or renegotiate partners to execute some of the initiatives that we may have written in our initial application. So those were just a few of the challenges. Some of the successes, we really didn't get to talk about that much, but we can say in Louisiana that, you know, partnering with higher education to create collegiate recovery programs has been a real thrill and bonus to work with that population. Expansion of recovery homes, implementation of harm reduction initiatives and campaigns, partnering with the Department of Corrections to implement medication for opioid use within jails and prisons, implementing Project Echoes, targeting FQHCs and targeting pharmacists. Also working with our birthing hospitals to implement screening, brief intervention, and referral to treatment are just a few of the successes we have here in Louisiana.
Thanks a lot. And we're thinking of you all and your neighbors as weather is coming near you. So please lean on us if we all can help. Thanks for that.
Thank you all so much.
We'll move on to group 5. If you could report out.
Sure. I'm Suzanne Boris from the state of New Jersey. And again, you know, I won't repeat things that are dittos that we have heard, but some of our issues were, again, providers not continuing with their contracts. You know, they might have won the award and then they don't want it for the second year, or they don't spend down the funding of the contract that they were budgeted for. Concerns about how to make programs sustainable after these funds are gone is an issue. In New Jersey, we often have a low response to our RFPs. You know, there's just not the provider interest for whatever reason. And even, you know, if we want to expand our contracts, we have a limit of you can expand by 20%. So that doesn't, you know, while that would be easy to do, we're limited. In terms of some of the positive things, one of our experiences was we implemented a fee-for-service treatment initiative called Recovery Care Management. We have some of our addiction programs are fee-for-service versus contract-based. And so there's lots of services that we get reimbursed for. You know, agencies apply to be in these. So what's been really burning money has been that fee-for-service initiative. And I have to actually move money to get more money into that. Another thing that we do well with are various prevention programs. We implement numerous evidence-based prevention programs, and they get implemented and done. And we also have in our state something called Jakarta. It's the Municipal Alliance program. So we were able to give money to them, and they could continue prevention work and amongst all the municipalities that belong to that in New Jersey. We did some public health campaigns. We ran 2 campaigns, so they were very impactful. And, you know, that was an easy way to spend money. We purchased mobile vans for our counties that didn't have mobile vans, so they could actually go out and outreach and meet clients where they're at. So that was an easy thing to do. One of the things we had was a transportation program we implemented where providers could bill us for getting clients to any kind of prevention, recovery, early intervention, or treatment program, you know, using bus passes, train passes, Lyft, and, you know, they would get reimbursed. And we also created a technology initiative where agencies could bill up to $50,000, you know, as first come, first serve for things to improve their technology, Wi-Fi, recovery apps, getting licenses to participate in different programs. I don't know if I'm missing some from our group, Nikisha.
I think you covered it all, or the majority of it. Thank you so much,
Okay,
Suzanne.
thank you.
Appreciate it.
Well done. Thank you very much. We'll go to group 3, please.
Okay, I will do the report out for group 3, and we had 4 states in our group. Our conversation focused, I'd say, on 3 categories: strategies for spending and targeting the funds, services that the states were able to fund and they felt were particularly effective using the supplemental dollars. And then we talked a little bit about the procurement process and maybe some techniques or strategies for often dealing with difficult state procurement processes. So I'll go ahead and share those items, and then if there's anyone from our group that wants to add or correct me, please do. So in the category of strategies for spending and targeting funds, I'll just provide 2 of those. One state shared that they spent their COVID funding first, their COVID supplemental first. And then what they did is they were able to leverage the ARPA funds to continue those programs and services, so to extend the life of those services. Another strategy that was mentioned is that in one state, for their ARPA funds, they decided to you know, spread those funds, allocate those funds through a request for application process. But what they did is they determined ahead of time that they would have applications in a couple different categories across the continuum: prevention, treatment, recovery, and then also crisis services, so that all of those areas received attention and funding through their application process. So that's the first group. The second group's related to services that the supplemental funds really help support, that they felt, you know, were extremely effective. And one was in the area of naloxone distribution, planning and distribution, and it helped that particular state rely less on the SOAR dollars. A lot of people talked about prevention and how the dollars really help them enhance their prevention system, including school-based prevention, prevention campaigns, and prevention specifically in tribal communities. And they also spoke a little bit about how the funds help support their workforce development efforts, which was extremely helpful. And then the last category in under procurement is we talked about some strategies that states use to help get those dollars out the door more quickly. And a couple of states mentioned that using existing contracts seemed to help a great deal with making sure those dollars could get out the door in enough time so that agencies had time to really implement the services. Although, you know, a number of the states also do use a request for application process. So they leverage their existing contracts. And then my last comment here is another sort of interesting example related to procurement is that for one state, they have a bridge period for existing contracts for a period of time, say 3 months, to allow projects to complete their service provision, close out their service. And so there's no gap in services while they are putting new contracts in place. And sometimes new providers are being brought into the system to implement their next round of contracts. So that is our report, but I don't know if any of the states that were part of Group 3 have anything to add or any corrections. If not, that is it for Group 3.
Fantastic. Thank you very much. And I want to thank you, Melanie Witter, Deputy Executive Director of NASDAD, for all the thinking that helped contribute to this event. Really appreciate it. We're going to go to Group 4. Before I do so, because of your modeling, we are a little bit ahead of schedule. So I just want to thank you for that. And I may quickly ask Dr. Olson or Spencer to add any a thought or two before we wrap up after Group 4. Group 4.
Hello, everyone. I will provide the report out for Group 4. There were 5 states in our group, and the main barrier that was consistent across all the states is where the intermediaries and contractors involved in the procurement process kind of slowed it down. And so what was done in terms of a creative strategy was exactly what Melanie said, using existing contracts. But what they did, which was really unique, is one of the states had created an addiction advertisement campaign with an existing contract. Another state was able to purchase a lot of naloxone, which kind of met their goals. And another state was focused on workforce development, was able to leverage a contract with the university that they had to provide more training, continuing education regarding outreach and other areas through that avenue. And then lastly, I'll talk about an innovative technology around workforce development. One state developed a learning management system online where they had providers be able to leverage different trainings. For example, they use the block grant supplemental funds to support a crisis curriculum for 40 hours, as well as a number of other types of curriculums through this learning management system. And that's all I have from our group.
Appreciate that. Thank you very much. That concludes the group report outs. I did want to allow Dr. Olson, if you had any last thoughts, observations as you heard from the report outs, or your colleague Spencer Clark.
Yeah, no, thanks so much. And thank you again, all of you for participating in this, for really thinking about you know, how we can also then learn from all the pieces that you've done, and also sharing some of those challenges and some of the strategies that you've identified to really kind of help address some of those pieces. I think, you know, the innovation, you know, both Tom and Rob, I think you mentioned it, as well as Spencer mentioned that the innovation here and the opportunity to really be innovative, even despite kind of some of those challenges and the constraints, that really came through to me. And so I've been like furiously taking lots of notes to also share with Tom Coderre, so that we really can highlight many of those. And I think that the idea of then how do we sustain many of those innovative services is a very good question. And yet at the same time, you've really been able to identify those things that are going to matter now, as well as then have some longevity, like all the workforce development pieces and the training and the technology and kind of investing in, even if it's these one-time things, that really they have longer term impact. So thank you all. I think we're going to continue to work with everyone, work with you all. This is only really the beginning, because we also know that that the people on the ground are the ones that we're all kind of focused on, and making sure that we're getting services across the continuum to all of them. So thanks so much.
Well, I just want to recognize Savannah, who put in some observations, some actions that Group 1 engaged in. So thank you for that. And that's exactly what we're looking to move forward and share. Well, I'm going to wrap us up. And as Dr. Olson said, this is just a dialogue that doesn't end today. Obviously, there's a lot more work to do and excellent opportunities to share. And technical assistance is available. States can access TA by emailing SAMHSA State TA team at SAMHSA State TA at JBS International, or by visiting state TA samhsa.gov. And next slide, please. And we're going to ask attendees for the webinar to complete a survey shown here. No good deed goes unpunished. We really want input, and we can't really continue to refine and help without your input. And the survey allows that to happen. And so with that in mind, you can access QR code by using your smartphone's camera. And the survey can be accessed via the link as well, which we'll also put in the chat. And the surveys, again, really important, because your feedback helps shape future webinars. So with that in mind, thanks for joining us today, and have a great rest of your day. Bye now.